My name is Purba Chatterjee, and I'm the Associate Director for Global Health Equity at the Institute for Global Health Sciences and the Department of OBGYN Bixby Center. It is my pleasure today to introduce Dr. Abel Kakuru, a longtime colleague of Dr. Grant Dorsey and other faculty here at UCSF. So just to tell you a little bit about Dr. Kakuru is an epidemiologist at the Infectious Diseases Research Center in Uganda and a lecturer at Busitema University. He holds a medical degree from Makerere University and an MSc in epidemiology from the University of London and a PhD in infectious and tropical diseases from the London School of Hygiene and Tropical Medicine. With over 18 years of clinical research experience, his work has focused mainly on malaria chemoprevention, particularly in pregnant women, where he has played a key role in many landmark randomized control trials to improve maternal and birth outcomes. He has also contributed to many studies on malaria prevention in children and the development of protective immunity. Dr. Kakuru currently serves as a co-investigator on major clinical trials evaluating novel chemoprevention strategies and continues to advance research aimed at reducing malaria burden in high transmission settings. He has an extensive publication record in leading journals and is actively involved in mentoring and teaching postgraduate students. And the title of Dr. Kakuru's talk today is Malaria Chemoprevention in Pregnancy. And I would also like to introduce, sorry, I just forgot to start recording. I would also like to introduce Dr. Grant Dorsey. Dr. Dorsey is a professor of medicine here at UCSF and is a clinician researcher and an expert in malaria prevention and treatment and has been working with IDRC for I think more than 2 decades now. And I've also had the privilege of working with Dr. Dorsey when I began my public health career at UCSF, and that was quite a while ago. Now, these talks are a part of the Institute for Global Health Sciences Global Partner Spotlight Series. And the goal of these talks is really to bring together diverse voices from diverse settings to share insights, challenges, and innovations that shape the future of global health. And with this, I would like to warmly welcome Dr. Kakuru and Dr. Dorsey. Thank you. Over to you, Dr. Kakuru. You may want to, yeah, there we go. Thank you.
Let me unmute. I always forget to unmute. Thank you so much, Puba, for the wonderful introduction. And thank you for the opportunity to present to this very good audience. And so I'm sorry, I'm in a store. I'm just presenting from a store, but please don't mind so much because I'm always in motion. I moved from Tororo to Kampala because I'm going to attend a meeting, but I made sure that I am available for this very important presentation. Thank you so much once again for the opportunity. So I am going to talk about malaria chemoprevention in pregnancy. A very important strategy for preventing malaria in pregnancy. And in this talk, I'm going to talk about the current evidence, the challenges, and then the emerging strategies that we are thinking about for preventing malaria in pregnancy, especially for chemo prevention. So a little bit about the burden of malaria in pregnancy. Women and children, of course, remain one of the vulnerable groups to malaria, and especially in sub-Saharan Africa, they bear the greatest burden. And in this setting of ours, Plasmodium falciparum is the predominant species. About 95% of the cases of malaria cases that are diagnosed, the species is P. falciparum. And in 2024, the WHO World Malaria Report estimated that 13 million women were exposed to malaria in pregnancy. And surprisingly, in these areas of moderate to high malaria transmission intensity, these pregnant women normally don't suffer from symptomatic malaria. It is normally asymptomatic because they usually have partial immunity, not sterilizing immunity. They normally get this immunity as they grow up in this area. They get partial immunity. So the infection is usually asymptomatic. It's usually asymptomatic, but it can lead to placental malaria infection, which is associated with poor birth outcomes and maternal morbidity. Poor birth outcomes like abortion, preterm delivery, babies are born early, or they are born small for gestation age, and weighing with low birth weight, and sometimes associated with neonatal death. So a little bit about the pathophysiology. Normally, the infection, as I had previously said, it is usually asymptomatic, but when they get this infection, the parasites normally sequester in the placenta by binding to chondroitin sulfate A receptors on the surface of the placenta, and this leads to accumulation of the parasites in the placenta, which leads to there is deposition of malaria pigment, and then there is a lot of inflammation happening in the placenta. The inflammatory cells accumulate in there, and this leads to placental dysfunction, and this placental dysfunction leads to the poor birth outcomes that we are talking that we normally see in our area, like low birth weight, like small for gestation age, and then sometimes babies are born early, especially if the infection happens late in pregnancy. So to prevent this burden of malaria in pregnancy, the World Health Organization has three main strategies, and one of them is the use of long-lasting insecticide-treated band-aids. This has challenges because there's pyrethroid resistance. Recently, we've moved to PBO nets, which are very good, but I don't know how long they will still be effective, because the parasites also keep evolving to overcome the interventions that we bring against them, and then prompt effective case management, and then chemoprevention, malaria chemoprevention. Chemoprevention generally involves the regular administration of antimalarials at specific intervals of time, regardless of whether someone has infection or whether the infection is symptomatic, and the aim is for preventing malaria. So, and this malaria chemoprevention this method that I've described is normally referred to as intermittent preventive treatment. And for the one that we use in pregnancy, we normally add the little p to mean pregnancy, but it can also be in infancy with I. My slides are not moving. So there's a few trials, historical trials that were conducted in the early 90s and the late 90s that were looking at, that established sulfadoxine-pyrimethamine as one of the that show that sulfadoxine-pyrimethamine is very good for preventing malaria in pregnancy. One of the studies was conducted in Malawi in 1994, where they gave pregnant women, generally all these trials, they were done in preemie and second gravid. That is one important thing to note, because I think because these are the ones who are who are more affected by malaria. So that's why these trials were done in the high burden groups. So in the first trial, they compared chloroquine. They gave chloroquine for treatment and then followed by chloroquine prophylaxis versus sulfadoxine for treatment, followed by weekly chloroquine, then versus sulfadoxine-pyrimethamine for treatment versus 2-dose IPTP in these women. And generally it showed that the women who were either treated with SP or were given SP following a dose of SP for chemoprevention, they had a lower risk of placental malaria. The same applies to Paris et al. This study was conducted in Western Kenya and in primi-gravid and second-gravid women, where they compared 2-dose sulfadoxine-pyrimethamine or monthly sulfadoxine-pyrimethamine versus case management, and both of them reduce the risk of placental malaria. But monthly, the reduction was higher with monthly sulfadoxine-pyrimethamine. And then another study was done in Kilifi, where they compared IPTP-SP versus placebo in primi-gravid women. For this trial, they looked at the outcome of parastemia and severe anemia at 34 weeks, and the trial showed that IPTP-SP was better than placebo. It decreased parastemia by 85% and anemia by 39%. So following these trials, in 2004, the WHO recommended IPTP-SP in all pregnant women. They didn't recommend it in only prime-gravid and second-gravid women who were the high-burden women. They recommended it for everyone. They thought it's very important for everyone. In women who were living in areas of stable malaria transmission intensity, and they recommended that it should be started in early second trimester. In the beginning, they were recommending 2 doses of IPTP-SP. In 2012, with that famous systematic review done by I think Kaintao, which showed that if the women received more doses of SP, at least 3 doses and above, the WHO reviewed its policy and recommended that women should receive at least 3 doses and a month apart, given at least monthly and a month apart, because this was associated with with a lower risk of low birth weight. However, this IPTP-SP since then has had major limitations because firstly, it cannot be given in the first trimester. In the first trimester, because it's an antifolate, we think it has a potential of being teratogenic because folate is required during organogenesis. And then again, the parasites have become resistant and there is widespread antifolate resistance, which is threatening its effectiveness, especially in East and Central Africa. So that is a graph of prevalence of markers of antifolate resistance across Africa. The graph on the left is showing the prevalence of K540E, and the one on the right is showing the prevalence of A581G. You can see that actually the prevalence is the prevalence of K540E is very high, especially in East and Central Africa. And then we are beginning to see this 581G creeping up, especially still in Eastern Africa, the southwestern part of Uganda and Rwanda. I think this is Rwanda. So both of these markers of antifolate resistance have been associated with reduced efficacy of SP for treatment of malaria. And then the 581G has been associated. If the prevalence is about 10%, then we see a reduction. We see a reduction in the effectiveness of SP to prevent low birth weight. And this, we have already started seeing that the drug is unable to clear parasites, and also its ability to prevent new infections is compromised. And that's the role of the chemo. That's the main reason why we give chemoprevention, to clear the parasites that are existing and then prevent new infection. So that is a graph that I extracted from one of our papers that we published in the Lancet. This study was conducted in Busia district in eastern Uganda between 2016 and 2018. I've removed the other graphs for DP. I just kept the SP in there. So you can see that at enrollment, about more than 40% of the participants had microscopic parastemia. And then when we used qPCR and combined with microscopy, it increases to more than to above 80%, which is really high in our setting. Then at enrollment, of course, we would later start when these pregnant women were enrolled. They were enrolled at 12 to 20 weeks of gestation, and they would be started on IPTP with either SP or monthly DP at 16 weeks of gestation or 20 weeks of gestation, depending at which stage of the pregnancy they were enrolled. So you can see that after starting SP, yes, it has some effect. There's some effect on the malaria, on the prevalence of malaria, but it's not optimal. You can see the prevalence remains high, even very high to the end of the pregnancy. In the third trimester, up to the end of pregnancy, you can see the prevalence is as high as 90, as high as more than 60% when combining qPCR and microscopy. So this shows that the drug is not working very well. We need to find alternatives for preventing malaria. So this is another these are results from another trial that we conducted. This was a secondary analysis we conducted in a recently concluded trial of DPSP. We published in PLOS Medicine, but this paper was published in CID, I think. CID. We looked at the risk of recurrent parastemia in pregnant women who received SP. So we got women who had parasite densities of at least 100 parasites per microliter, and we asked ourselves, if we gave them SP, were they able to clear these parasites? And then if they are not able to clear these if we detected these parasites following starting SP, are these parasites new parasites or old parasites? And you can see the cumulative risk of any recurrent parastemia is really high in our setting, and it decreases with gravidity as expected, because gravidity is associated with immunity, because gravidity is associated with immunity. And then also you can see that the cumulative risk of recurrent parastemia due to recrudescence is very high. So 58, 54, over 50% of the people, of the pregnant women who were pregnant for the first time, the prime gravidas, were not able to clear the parasites. And then it reduces as gravidity increases. So we need alternatives for IPTP SP. For SP, we need alternatives to SP for IPTP. And there are very many studies. A number of studies have looked at different alternatives. Mefloquine was compared to SP, and in one of the trials, it was associated with reduced maternal parastemia delivery, reduced maternal anemia delivery, but did not reduce placental malaria. And importantly, it was also associated with vomiting and dizziness. So it wasn't well tolerated. So another trial evaluated SP plus amodiaquine, and this trial showed no differences in the risk of anemia and adverse birth outcomes. And also this drug was not well tolerated compared to SP, so we never thought of carrying it forward. Then one other trial combined azithromycin plus chloroquine, and the primary outcome was a composite adverse birth outcomes. This study was stopped early due to futility, and there was no difference in the primary outcome. And azithromycin plus chloroquine was poorly tolerated compared to SP. So all these were non-starters. So we have studied dihydroartemisinin-piperaquine widely. Our group and others have studied this drug. It's very good for treatment of malaria, and when it's used for treatment of malaria, its partner drug, the piperaquine component of the drug, gives a longer prophylactic effect. So it's highly efficacious in treatment of uncomplicated malaria, and then has long post-treatment prophylactic effect. So we went ahead and tried this and studied this in two studies, one conducted by ourselves in Tororo, and another one conducted by our colleagues in Kenya, in Western Kenya. And in these two studies, we showed that IPTP-DP was associated with a low risk of symptomatic malaria and asymptomatic malaria during pregnancy significantly, and then it also reduced the risk of malaria infection and placental malaria at delivery. However, despite those great improvements in the malaria parastemia and the risk of placental malaria and clinical malaria, we did not see any difference in birth outcomes. These studies had limitations. Firstly, IPTP-SP was not given monthly, and we did not power these studies to detect a difference in adverse birth outcomes. So we went ahead and conducted another trial in over 700 pregnant women. This trial was conducted in Busia, and we compared SP, monthly SP, to DP in a double-blinded randomized control trial. And we found that compared to SP, DP was associated with a lower risk of symptomatic malaria and asymptomatic malaria during pregnancy and placental malaria at delivery, like what we had observed in the previous study in Tororo and the other study in Kenya. However, we still did not see any difference in birth outcomes between DP and SP, despite powering this study to detect a difference in the risk of composite adverse birth outcome, which included preterm pregnancy loss, preterm delivery, low birth weight, small for gestational age, and neonatal death. So we thought, maybe could this be due to additional non-malaria benefits of SP? Because SP is known to have antibacterial effects, just like its sister drug, cotrimoxazole, which is used for prophylaxis in people living with HIV, and it's also has some effect on malaria. So we thought maybe the additional non-malaria benefits of SP were the ones that were making us fail to see a difference compared to DP, despite DP being great at reducing parastemia and placental malaria. So this is another study which also looked at which compared monthly intermittent preventive treatment or with the dihydroartemisinin-piperaquine, and this time they added azithromycin, and I think they also had an idea of adding a drug that has antibacterial effect to see if it was better than monthly sulfadoxine-pyrimethamine on improving adverse birth outcomes. And they were also disappointed. DP-containing regimens were associated with higher risk of a composite adverse birth outcome. And this also, they discovered that the risk of the difference in adverse birth outcome was largely driven by low birth weight, the risk of low birth weight, and small for gestational age, not any other adverse birth outcomes. So we thought, could this be due to the non-malaria benefits of SP? So we went ahead and conducted another trial in Busia, which we have recently concluded, and then it was published in PLOS Medicine. We combined dihydroartemisinin-piperaquine plus sulfadoxine-pyrimethamine, comparing it with either drug alone, the DP or SP, in over 2,700 pregnant women, and the primary outcome was a composite adverse birth outcome. Women were enrolled at 12 to 20 weeks of gestation and given study drugs. These study drugs were given in a way that you would be given a dose today of DP, then tomorrow we give you the other doses for the subsequent 2 days to take them at home. So those were not direct observed. But the first dose was always direct observed, meaning SP was all directly observed. And what we saw is that DP plus SP did not improve birth outcomes compared to SP or DP alone. And in fact, we observed a higher risk of parastemia during pregnancy and placental malaria comparing DP plus SP compared to DP alone. So adding SP to DP reduced the efficacy of DP, and then DP-containing regimens were also associated with a higher risk of small for gestation age and low birth weight among gravid mothers. So this association was only observed in multi-gravid mothers and not primi-gravid mothers. And we think maybe we didn't observe it in primi-gravid mothers because the effects of DP in preventing malaria are great. And these are the people who would expect to be at a higher risk of getting adverse birth outcomes. So its challenges with not improving birth outcomes are overcome by its efficacy being a great drug at preventing malaria-associated adverse birth outcomes. So we went ahead and looked at what were the possible reasons why we didn't see a difference, and we found that actually, although we didn't expect these drugs to interact, they interacted. These drugs interacted, and administering DP and with SP was associated with a lower concentration of both drugs, that is SP, then that is sulfadoxine and pyrimethamine on day 23, and then also the area under the curve for piperaquine was affected. Maybe that could also explain the reason why we see a higher risk of parastemia during pregnancy and placental malaria compared to DP alone. And then we think also the reason that we observed this difference, it could be that DP also may be reducing birth weight on its own. Not that SP is improving birth weight, but DP is reducing birth weight despite being a very good drug at preventing malaria. So what are we looking forward to? We are looking at the potential of monoclonal antibodies. These monoclonal antibodies are in the pipeline. Our team is currently studying MAMO1, but this is in children. We haven't yet tried it in women of childbearing age, but cis and cis 4-3 LS and L9 LS, these ones have been L9 LS has been tested in women of childbearing age. So these monoclonal antibodies have potential. They block p-phosphorin pyruvate before they enter the bloodstream. That's how they act. And the L9 LS, which is being tested currently in Mali, is being evaluated in Mali. We are waiting for the results, see how safe it is, but we hope the results will be very, very promising, because the MAMO1, which we are giving currently in children, it has been very well tolerated. But however, MAMO1, we are not thinking about trying it in pregnant women. Why? Because we think the dose that is required for prevention of malaria in adults is much larger, and it will be very expensive. So it may not be very cost effective to try MAMO1 in pregnant women. So it may not be a very good drug, but who knows? Because if we can show that it works with technology, they may be able to refine it so that they reduce the dose and make it affordable, so that it can be used to prevent malaria. So these monoclonal antibodies are injectable, and they are given like once, and then it prevents malaria for about 6 months. So we hope these will be tested in pregnant women, and then they'll be shown to be effective. Then we are also thinking about the long-acting injectable antimalarials. Currently, Medicines for Malaria Venture has developed one product, which is MMV371. It's a derivative of atavocone proguanil. This one Grant used to take it alone marathon before he discovered that dihydroartemisinin-piperaquine is very good also at preventing malaria. This is used in travelers. It's very safe in travelers. So currently, this is a single dose injectable formulation and provides up to 3 months of protection if someone receives it. Currently, there is an ongoing phase 1 clinical trial in healthy adults in Nottingham, in the UK, and it's assessing the safety, tolerability, and pharmacokinetics. And they are evaluating 3 doses. Those 3 doses versus placebo. And trials in malaria endemic settings will soon be following. I think they may be planning to conduct one study in Rwanda, because we were in touch with the team that is currently evaluating this drug in the United Kingdom. Then we also are thinking of vaccines, but these are not. This is not intermittent preventive treatment. It's not chemoprevention. It's not in the grade of chemoprevention, but it's one of the other promising alternatives for prevention of malaria. So these vaccines, they target they target preventing placental malaria. The first-in-human trials have been conducted. They have been shown to be immunogenic, and they are safe in a few adults. And we hope phase 2 trials will soon follow, and then we'll be testing these vaccines in pregnant women. So in summary, chemoprevention with SP for IPTP remains suboptimal, and it fails to clear parasites and prevent new infections. We urgently need alternatives, because I showed you how the prevalence of parastemia during pregnancy is really very high. So this drug is actually like a placebo. The only reason we are continuing with it is because it's associated with a higher. It is associated with a reduced risk of low birth weight. So you are more likely to deliver a big baby, And in our study, we showed that actually the babies are born 100 grams heavier when they are on SP compared to when they are on DP containing regimens. Whatever that means, what is the implication of that in public health? I don't know. Then for dihydroartemisinin-piperaquine, it's not adequate for IPTP. It's an excellent anti-malarial, but it's not adequate for IPTP because we think it is the one that is reducing birth weight, especially among multigravid women who are less at risk of malaria in pregnancy compared to prime gravid women. So future research areas, we need to look for alternative drugs for IPTP. And if we are looking for alternatives, we need to look for alternatives that can also be used in the first trimester, because currently we don't have any drugs to use for prevention of malaria in the first trimester. It's only AL that we are using for treatment. And we don't have anything else for chemoprevention in the first trimester. Then we need to think of optimizing the dihydroartemisinin-piperaquine by trying to evaluate which component is actually associated with a reduced which component reduces the birth weight. Is it the artemisinin component or the piperaquine component? Because who knows, we can still use piperaquine in combination with other drugs for prevention of malaria in pregnancy. Many thanks to the hospitals where these studies were conducted, then our collaborators from UCSF, and then finally to UCSF Institute of Global Health Sciences for the opportunity to present our work. Thank you so much.
Great. Thank you so much, Dr. Kakuru. Before we sort of transition to the next section, I just want to mention that I see Dr. Payam Nahid, our Executive Director for the Institute for Global Health Sciences, is here, as well as the Deputy Director, Andrea De Luca. So welcome. And I just want to hand it over to Dr. Dorsey to get us started with the Q&A section.
Great. So it looks like we have about 20 minutes left. I have some questions I can ask, but I think I'd rather just kind of open it up for questions from the audience, just to make sure that those of you that took the time to join us have an opportunity to ask questions. So I think probably the best, if you just want to raise, if you have a question, maybe you could just raise your hand. You could also put it in the chat, and then we can let you ask. But while we're waiting for people to raise their hands or put questions in the chat, let me just start with a question for Abel. So I find this really, thank you very much for the excellent presentation. I find this really a very interesting, challenging situation that could potentially be applicable to other diseases, especially other infectious diseases, is you have this intervention that was, studied with fairly rigorous placebo-controlled trials several decades ago that demonstrated a benefit. And at that time, the parasites were sensitive to this drug, sulfadoxine-pyrimethamine. And then that becomes the standard of care. And then, as time passes and the parasites have developed resistance to sulfadoxine-pyrimethamine. As you know well, this is a drug that we used to use to treat malaria, and now we would never treat it for malaria. If you give someone SP to treat malaria, they do very poorly. But because we're giving it for prevention, it's kind of harder to see it failing. It's more of a challenge. So my question is, really the only way to really definitively know if SP is still working would be to repeat these placebo-controlled trials in this current environment. But there's, the ethics of that, like when something becomes a standard of care, it's kind of assumed that it's not ethical to not give it to people in trials. So my question to you is, do you think that it would be ethical, or do you think you could, or there's benefit in conducting a placebo-controlled trial of SP to really get at this question of, is it actually beneficial?
Thank you so much, Grant. Yes, it would there would be a benefit in conducting a placebo randomized control trial, but as you have hinted on it, that it would not pass the ethics boards, because there is a standard of care, which of course we know is not working, is as bad as good as a placebo, is not working. So they would find it very hard to let us conduct a trial where we are comparing the standard of care, or even the placebo, the SP itself, plus the comparing it with a placebo. So it would be very hard. The biggest hurdle would be the ethics hurdle, having it cleared for that. Jimmy, you have your hand raised.
Dr. Kakuru, maybe you can stop sharing your slides and we can see everyone, if that's okay.
Okay. Let me stop
And there is a
sharing.
question from Jimmy. If you want to unmute yourself, maybe turn on your camera.
Oh, thank you, Chair, and thank you, Abel, for the good presentation. I have a question to bring, like, what do you think the effect of, you said DP reduces birth weight generally, and you said the weight is not that much. So do you think these children catch up when they are born in their first year of life? And can that be used as a point to argue again, because the negative effect that we are seeing of DP being an excellent anti-malaria, but it has an effect on birth weight. But to what extent is it? And do you think that clears or that levels when with other children who are on other drugs?
Thank you. Thank you, Jimmy, for that very good question. Actually, in our studies, as you already know, we follow the participants, the children that are born to our participants. So we have birth cohorts, and we take weights of these children, length, and height. So we are able to look at how they are faring with regard to growth in comparison to how they were born at that time, if their mothers received either DP or SP for prevention of malaria in pregnancy. Generally, the what we observe, of course, is they are born smaller. The ones on DP are born smaller, and it looks like from our one of the studies, one of the analyses that we've conducted in the ongoing birth cohort that we are currently following, it looks like it looks like they actually fast catch up, but because the ones in our birth cohort, some of them are on DP, some of them are on DP. DP is associated with reduced growth, like weight for height. These scores are generally lower for the children who are on DP. But of course, this is the chemoprevention in children. But generally, if you look at the ones in the birth cohorts that we followed up for the study that we published in the Lancet, they normally catch up. They catch up as by like the third month, they catch up if they are not continued on chemoprevention with DP. Correct me if I'm wrong, Grant, but by the third month, they start catching up, irrespective of whether their mothers received DP or not.
Yeah, I think, that I would agree. I think to put it in context, Jimmy's question is that, when these original trials were done, some of them were able to show that this intervention IPTP-SP would reduce the risk of low birth weight. And then they basically using deductive reasoning is other studies show that kids that are born with low birth weight are at higher risk of neonatal mortality. So although there's never been an IPTP trial powered to show a reduction in, neonatal mortality or infant mortality. But, so the thought was that, if you reduce the risk of low birth weight, that's a good thing, which is probably true. But, now it's kind of creeped into like just, lowering the birth weight by 100 grams. Is that, really that bad? So I think it's a reasonable question. And just as you said, from our birth cohort studies, when we follow these kids, it looks like this corrects after about 3 months. I see Mary Pra's a question. Mary, and if you want to, you can do a quick introduction, say who you are.
Okay.
I think you know Abel, so you can.
Yes, I know
say
Dr.
hi.
Abel very well. So I want to say hi. I hope you're well. I'm a pediatric infectious disease physician. I've worked with Dr. Abel quite a long time ago. Now I've transitioned to other infections in pregnancy and early childhood. But my question is going back to SP and thinking about SP as having kind of maybe off-target effects or on other infections. Do you have a sense of what you think SP could be working on as far as other infections that it's treating in pregnancy, either gastrointestinal, sexually transmitted infections, or kind of hone down on what we think that kind of other off-target infection prevention could be?
Thank you, Mary, for asking that good question. We actually looked at the risk of sexually transmitted infections, but we only did it at delivery. So we looked at it at delivery, and the only effect it had SP was on chlamydia, not any other. Gonorrhea, there was no difference. It was only chlamydia that it reduced. And Grant, isn't it?
Yeah, that's correct. So there was a significantly lower risk of chlamydia infection at delivery in women that got SP compared to women who got the DP alone. However, it's a relatively uncommon outcome, our just ability to detect it. And although the effect size was pretty impressive, it's not clear that it would explain, the difference in birth weight that we see. But it's definitely it's a great question, by the way, and it's interesting. And we've also, have kind of done some stuff looking at the microbiome and stuff, and but those results are not yet available. Let's see, are there other questions? Payam, excellent.
Hi, Grant. Hi, Dr. Abel. Nice to meet you. I really enjoyed your presentation. I'm very interested in your closing comments about long-acting injectables and the monoclonal antibodies and how to approach that in development for pregnant women. Many fields, pregnant women are excluded from clinical trials until years after the drug hits the market. Could you sort of maybe describe what the challenges are and what some approaches might be to not leave pregnant women out of the advantages that those agents bring?
Thank you, Pam. That's a very good question too. You're right. Pregnant women are normally excluded from trials, and somehow they end up receiving. They end up not receiving good interventions because we want to protect the babies, especially in the first trimester. A case in point is ACTs. We've just recommended ACTs to be used in the first trimester, but ACTs have been around for so long, and these pregnant women were using they were using quinine, which is not a very good drug for treatment of malaria in the first trimester. So we are trying to move away from this, and us and our colleagues, our collaborators from University of Liverpool, from Cambridge, we are conducting trials now in the first trimester, Sapphire. We're looking at the safety of antimalarials in the first trimester, because we think women should be encouraged to, women should be involved in trials as soon as possible, provided animal studies have shown that the drugs are not teratogenic, they don't affect babies, then we can try them in women on a small scale, so that we don't take a very long time to give them these interventions once these interventions have been shown to work very well. Now, like the current ongoing trial in Mali, which is looking at monoclonal antibody L9LS for prevention of malaria in adults, they've included women of childbearing age, so that if any gets pregnant, of course, they always tell them to use a contraceptive to prevent pregnancy, but ultimately some of them end up getting pregnant. When they get pregnant, then we can be able to see whether it is safe or not. But we don't expect like monoclonal antibodies to be reactive to be teratogenic. We don't expect them to be teratogenic, but who knows? We don't expect them to be teratogenic. The long-acting monoclonal antibody, I don't know. The long-acting injectable drug, I don't know how safe it is in the first trimester, but maybe the travelers can tell us, because it is used. Part of it is used as Makerere for preventing malaria in travelers. So, are there travelers who have been on it who have got pregnant? Maybe we can look for literature with regard to that, and we'll be able to extrapolate whether it's safe or not, whether it's likely to be safe in the first trimester or not.
Great, thank you.
Okay, I see Michelle saying you have a question.
Thanks, Grant. Thanks, Abel, for a great talk. Just two questions. Like, one is, have you had like discussions with the Ministry of Health regarding these findings, and what are they thinking about in terms of like policy for IPTP? And then just my second question is just, are you or are others doing work around targeting women like pre-conception? Because it just seems like waiting until, after pregnancy, you're missing out on a window where you can really have an effect. I mean, irrespective of what the intervention is, like, are there ways you can target women? For example, like I'm just thinking about when I started taking folate, when I was starting to think about pregnancy, are there things that like cultural traditions that women take part in, like before, when they're thinking about pregnancy, and could that be leveraged?
Thank you, Michelle, for that question. Our results, we always present our results to the Ministry of Health, and yes, they are impressive, but they think they will not be able to change policy, because the only recommendation that we would have is from our results is that DP is very good for preventing women in primogravid and primogravid women, prim and second gravid women may benefit from this intervention of DP compared to multigravid. But it will be very hard to implement where you're only giving it to primogravid and second gravid, and then ignoring the multigravid women, because among the multigravid women, that's where it was associated even with low birth weight. Yes, we engage the Ministry of Health and disseminate our findings, but we don't expect them to change policy based on the findings that we have got. Then for the question of whether women before they get pregnant, which things do they participate in, whether they can be leveraged. Actually, in our setting, many women, when they get pregnant, they actually don't want you to know, Ali. So they keep it as a secret. They want to keep it as a secret. Then they wait for it to show itself. That's actually the main reason why women attend antenatal late. They normally come in the second trimester when the baby has started kicking. But we are trying to encourage them to come for antenatal early. But still, we currently don't have any other intervention apart from the long-lasting insecticide treated nets as a preventive measure for pregnancy in the first trimester, because the rest of the interventions, we don't know how safe they are. And then, of course, IPTP SP is presumed to be teratogenic because of its antifolate effects.
Thank you.
So, Purba, I think we're pretty close to the top of the hour. I don't know if you want to make any final comments or.
I just want to thank Dr. Kakuru and you, Dr. Dorsey, and everyone else here for making the time to join this talk. And I don't know if Dr. Nahid has any comments, final comments, or no? Okay. Thank you for a really excellent talk and a very engaging discussion after. So thank you.
Yeah. Thank you, Abel, for doing this, and for all the people that joined and the excellent questions. It was really made my job easy, certainly. So thanks, everyone. And thanks for
And thank you,
organizing.
everyone.
Bye-bye.
Okay.
Thank you for the opportunity. Bye.
Bye.
Thank you.
Bye, Abel.
Bye.